क्योंकि मैं सिस्टम प्रेफरेंस सही कर रहा हूँ सर मैकबुक का। अभी हो जाएगा, अभी हो जाएगा।
ओके ओके ओके।
और इनकेस नहीं भी होता है तो
welcome everyone. So we are going to have our monthly webinar under aegis of Arthroscopy Association of UP. So today we have speakers from Gorakhpur Orthopedic Club, Dr. Satpal, and a versatile orthopedic surgeon. He's my colleague also. He has been my batchmate, and he does all kind of arthroscopic surgeries and trauma surgeries. He's a very accomplished orthopedic surgeon from Gorakhpur. Dr. Imran Akhtar, another very dynamic arthroscopic and trauma surgeon and joint replacement also from Gorakhpur. And Dr. Amit Mishra, who happens to be secretary of Gorakhpur Orthopedic Club, and he's one of the speakers for today as well, along with Dr. Imran and Dr. Satpal. So Ashish sir, I think you can start and have an introduction about the faculties and the panelists, and then we can start the session. Ashish sir.
Bilkul, by Vinay, thank you. And I'm grateful to Dr. Maheshwari and Dr. Deepak Chaudhary for their appearance and contribution he is going to give regarding the knowledge of the arthroscopy that they have a vast experience. And you have introduced the speakers, and we all are the members of our association and the family. So, and we were talking about the webinar. Our physical meet is on 5th and 6th. I formally invite both of you, sir. So if you can grace the occasion, we'll be more delighted to have you in our meeting, 5th and 6th of November at Lucknow. And Vinay, please go ahead with the presentations, I think, so that we have more time for the academics.
Thank you, sir. So Satpal, you have the first presentation ready for the day. Your first case is ready.
Yes.
Okay, you can share the screen.
Good evening, everyone. I'm going to present two cases, one for PCL avulsion fracture, arthroscopic fixation, and another is median and lateral meniscus repair. I'm sharing my screen. My first case is on lateral meniscus tear. 21-year male came to me with history of fall from his scooty 4 months back. Complaint of pain, instability, right knee. On examination, no joint line tenderness. Anterior door test was positive. Left main chest was positive. X-ray, there is normal. This is no pre-operative X-ray. And no. This is a coronal and sagittal view of his MRI, showing complete ACL tear and no any meniscus lesion seen on MRI.
Satpal,
yes.
Sorry to interrupt. What we can do is, if somebody has to ask question during the case about history, if you want some information, they can ask. Is it okay with you?
Yes, this is okay.
So Maheshwari sir and Chaudhary sir, if you want to ask some question pertinent to history, or maybe you want something about from the X-ray, you can ask, no? So that's not a problem. We can go at discussion. Discussion.
We will make it more interactive.
Interactive, yes, sir.
Yes.
On the MRI in the sagittal view, there is some hyperintensity in the lateral meniscus. Is that normal?
Satpal, you have more images of the lateral meniscus.
At present, I have only these two images.
You said this was a case of ACL with lateral meniscus.
Yes, ACL with lateral meniscus.
But you said meniscus
per operative finding.
Okay.
On arthroscopic finding, there was cleavage tear in the lateral meniscus. And I repair lateral meniscus all inside technique using first pass mini or scorpion. This is a video of.
All right.
Dr. Satpal, did you look for the root, whether the root is normal? Because
Yes, sir. Root was normal, sir.
Because in young patients, ACL with lateral meniscus, one must look for root. Sometimes it's very difficult unless you
Sir,
specifically
root was
probe for
normal.
that.
Root was intact. Not there is no tear in the root.
Okay.
And this is a 1 month post-op.
Did you do ACL reconstruction as well?
Yes.
Okay.
This case was done 1 month back, sir. So I have only this.
So in 1 month, you have removed the braces, or it's still on?
It's still. While walking, he used brace in full extension.
Okay.
Partial non-weight bearing for 6 weeks, and partial weight bearing I started after 6 weeks.
So there was this discussion in the recently concluded IAS meeting. I don't do meniscus repairs, Vikram does it. But I know, and I was very uncomfortable all the time, that he used to keep patients non-weight bearing in a brace for 6 weeks. To me, that was like torture. And I always used to poke at him that maybe you're not up to date, you please read. It's not fair to have non-weight bearing for 6 weeks in a brace is like a torture. So in the meeting, there was a panel discussion, and there were 5-6 people sitting on the dais, and I asked all of them, what is your protocol? And what I understood from their protocol is this: radial tear, non-weight bearing from day 1 till 6 weeks. Peripheral meniscal tears, weight bearing as tolerated from day 1 walking. Some people said restrict for 2 weeks, but nobody was more than 2 weeks non-weight bearing on a peripheral tear. That means a bucket handle tear. And knee movement allowed from day 1 till 90 degree at 6 weeks. So beyond 6 weeks, 90 degree. And this was a very, very understandable concept, because when you do weight bearing on a bucket handle tear, you don't harm the repair because it only pushes it outer way. And number 2, bending of the knee, meniscus is disturbed only when you go beyond 90.
Right.
Obviously, after surgery, it is very difficult to go beyond 90 for 4-6 weeks. You can be late. But radial tear, you cannot weight bear because that will open up. So I think after the discussion in last month meeting, and Vikram was also there, and I was hedging him all the time, because this seemed to be the concept of weight bearing and bracing after meniscus tears. So this is just because I was there, and I thought I would bring this out, and I purposely asked this question because I was not very in alignment with conservative approach of Vikram.
Dr. Maheshwari, I completely agree with you. I was recently at Chicago and attended this advanced knee at cadaveric course under Dr. Rob Leprede. And the similar concepts were there. For a root tear or a radial tear, yes, you need to restrict weight bearing for the 4 to 6 weeks. But in rest of the tears, unless your fixation is in doubt, you should allow weight bearing as per your pain limits, because that promotes healing. And I totally agree that knee bending, again, within the first few days, it should one could be easily able to achieve 90 degrees, because that also helps in the healing of the knee.
Right. So I think this is a take-home message from this presentation, that you can be a little more aggressive with your weight bearing and mobilization.
Maybe Satpal, once he's more, doing more of meniscus, then initially we were also a bit afraid. But yes, we are getting some counter sounds, some back sounds are there.
Okay. And the other thing is, I think on the MRI, there was a very nice lateral femoral contusion, bone contusion. That's a very good sign if you're doubtful about ACL injury.
ACL, yes.
Sometimes those indirect signs are very helpful.
Very important.
That the patient is pivoting. So
Exactly.
if you're doubtful about whether you should do or you should not do, sometimes patients don't give clear history. I think that contusion is a very clear sign that this patient was pivoting and he has pivoted. Otherwise, that kind of injury cannot happen.
Contusion on
So
the
one,
lateral femoral as well as on the posterolateral aspect of the tibia, Dr. Maheshwari. I think
yeah,
both
sometimes
are
even tibia, even here, I think tibia is also involved. I can't
on
see.
the
I'm on the
coronal.
phone.
On the coronal, you can appreciate there is.
Yeah. I'm on
Is
phone, so
there,
I can't see it so clearly, but yes.
is there any role of taking the flap off? I'm talking about not everybody can perform all inside meniscal repairs. So what is the role of taking the one flap off and the other flap acts as a meniscus? Is there any role of in this
Uh,
horizontal scenario?
Can I step in, Dr. Maheshwari?
Yeah, sure.
So at the recent Lapredes meeting, they showed convincing evidence that whether you remove half a flap or full flap, that increases the contact stresses. So the current thinking is that in horizontal tears you must try to stabilize and repair the meniscus to restore the function of the knee and the normal biomechanics and the kinematics of the knee.
Okay, Satpal, you can move to the second case then. No?
Second case. This is for medial meniscus tear. A 22-year male came to me with history of fall from while playing football 4 years back. Presented with pain and locking instability in his knee. On examination, medial joint line tenderness was present. McMurray test was positive. Leishman test was positive. Anterior test was positive. X-ray is normal. There is no significant finding. On MRI, there was bucket handle tear and a double PCL sign was present. And this is a on arthroscopy examination, I found there was double bucket handle tear. I removed with punch and saver inner fragment. And repair the outer all inside out technique is this using zone specific cannula. This.
So basically, the medial part of the bucket handle was taken off. The more medial part.
Yeah. Yes.
Or the more lateral part.
In a white.
So tell me, when you're doing inside out, do you make a safety incision?
Yes, sir.
Medial? Hello?
With ACL with medial meniscus ACL tear, I use the graft harvested incision as a safety incision, and go percutaneously and retrieve the.
No, but that incision is too anterior. Graft harvest. I'm talking about posteromedial safety incision.
Yes, sir.
Left angle. Yes. Yeah. So that
yes,
was another discussion. Yeah, that was another discussion. Okay. Yes. So that was another discussion that happened, and of course, again, I was very primitive in repairing meniscus long back, and I've not done it for last 4-5 years. Vikram does all the time. But I think that inhibition not to make posteromedial incision is not correct. One should, for two reasons. One, you limit the damage, possibility of damage to neurovascular bundle or whatever surface. More importantly, sometimes you can you may not be able to actually tie it down right on the capsule. If you work through those mini tiny incisions, you tie your knot on the fat pad, etc., and that loosens out. So if you make a safety incision, not only is it safe, it is easy, but also you can remove the fat pad from the capsule. And when you're knotting it with the help of a knot pusher, not with hands, knot pusher, use a shoulder knot pusher to tie it down right on the capsule. That gives a real, very, very secure repair of the meniscus. I think that was another point which came up in the discussion, and most accomplished surgeons said that is the right way to do it. So get out of the inhibition of not making that incision. If you are doing such an extensive inside out, I think it is worthwhile making that incision.
Dr. Maheshwari, we have a experience of now over the past 4 years of more than about 50 bucket handles, and we have repaired mostly with all inside with very good results, and not a single bucket handle we had to do a re-scopy for any failure of repair, but rather many other cases like horizontal or even some longitudinal tear we had to scope in again because of the re-tear or some portion which had not healed. But bucket handle, we have found that results are very good because most of them, they are perhaps in the red white or the red zone, and the healing is very good in bucket handles. It is only we have been able to use all inside for the even till the quite anterior part of the bucket handle as well.
Yeah, I agree, but then all inside is very expensive.
Yeah, that's true, but that is our patients are quite affording, I think.
Yeah, I know. For in general, one should be able to do inside out, very, very painstaking. It takes time. It is very, very low technically demanding.
Yes.
But if you do it with a safety incision. That's my point.
Carl, do you do pike resting for MCL for a medial meniscus repairs?
That should be done. That because ultimately the aim of meniscal repair is to save the cartilage. And
yes,
if you do not able to open the joint and reach there properly, you will be causing a lot of cartilage scuffing. So we do it quite routinely unless it has a very lax.
I'm doing routinely the pike resting.
That's true.
Deepak sir, what's your landmark for putting a pike resting? It is on the tibial side, joints line, or it is on the
it is the posteromedial aspect of the tibia and even in the joint. Sometimes we even do the femoral. It is it's possible everywhere. And sometimes in our initial cases, we even used to, while harvesting the ACL graft, some part of mesial piece, this MCL, we used to just elevate with no bad results or ill results. So, but pike resting is very important because unless you are able to reach with your equipments, you will be causing cartilage scuffing, which will defeat the basic purpose of meniscal repair.
Maheshwari sir, any side effect or any flip side of pike resting that you have experienced in your practice, that maybe loosening of the middle compartment, MCL loosening?
No.
Have you ever encountered this?
No. I think it's a very. I was very hesitant to do it, but I've seen there's no problem. Now I only follow up the patients. I don't operate, but I see there's no problem. I was very hesitant, and Vikram really opened.
And how soon you start knee bending?
Because they
inhibit knee bending?
No.
They immobilize for 2-3 weeks anyway, which they may reduce the immobilization now, but I don't think MCL is a good ligament to heal. So I don't think one should worry.
We allow knee flexion from day one, and most of our patients within the first 2-3 days they achieve 90 degrees of flexion after repair.
Sir, can I ask one question?
Yes.
Sir, what is the maximum duration up to which in bucket handle tears you are repairing cases?
So there is actually, Imran, it is not the duration. It is very important. What is the quality of the meniscus? We have, you will be surprised that we have operated one patient which was 8 years old. 8 years old, and it was completely locked. We somehow managed to reduce the meniscus. We freshened both the ends thoroughly. We created a lot of local biology by rasping, by shaver, by using needle. And we did even a 1-year follow-up MRI scan of that patient. Good healing, clinical as well as radiological. So I don't think long duration, but yes, quality of tissue, vascularity, that is more important rather than the duration.
And how to check the vascularity of the fragment of the bucket handle?
If it is in the white zone, you can see if it is like completely fluffy with lot of, you can see whether it is healthy or not. But this 8 years old was not very healthy, but still we took a chance, and the patient was young, he was athletic, so we took a chance, and it is now 2 years and he is doing quite well.
Deepak sir,
with indication of doing inside-out repair, any case that you would recommend to do an inside-out repair?
Actually, I have rarely done inside. I am using that instrument of this striker, which is inside out, but otherwise our most of the cases are all inside, and in the most anterior part we use a simple needle technique to do outside in. Actually, I do very little inside out. And this is the trend worldwide, Dr. Maheshwari. When I was recently at that, most of the people, because of the constraints of time and wherever financial constraints are not there, they are this all inside devices with the latest, which can be molded. They are using these all inside devices. And in a bucket handle, we have used close to 12 to 13 all inside devices.
So Deepak sir, up to which age you are doing the meniscus repair? The maximum age limit?
No, that is not an much indication, because it is in the age category 45 to 55, the females which we come with root repair, that is commonest in this age group. They also have a associated horizontal component. So there is no age bar like that. And if the patient, otherwise it is not arthritic, otherwise cartilage is healthy, we do have done meniscal repairs in 50s as well as even in early 60s as well.
Okay.
Maheshwari sir, this is a question. So if you have to talk about one flip side of these all inside devices, what would you tell us with your experience of using these all inside devices? Any particular problem with these devices?
So as I told you, I am only following up, so I can tell you the downside.
Hello?
Because mostly Vikram does it, and I have to face the music. So there are at least 2 cases in last 2 years, where in one case there was persistent effusion, and we aspirated, and we were fed up, and finally I said I have to do scopy again, because I'm a little bit skeptical about repair of meniscus even today, though there are no major problems. I don't think all menisci heal. It is just that you tie them there with non-observable sutures, they remain there. Whether they heal, even the literature says almost 40-50% don't heal, but they remain there and provide whatever function. So in 2 cases, persistent effusion, there was this all inside device was hanging around there, and I had to remove it. I had to do a meniscectomy, and then only patient settled down. So if you are using all inside alone, and be very liberal, don't be Baniagiri. So Dr. Chaudhary works in a different setup where he can use 10, 12. Otherwise, they are very expensive devices. I would say use inside out as much as you can, because they're cheap, they may take more time, they're quite safe, and use all inside liberally. Ultimately, your repair has to be good. Otherwise, that all inside 1 or 2 that you put because you don't want to spend more money will actually become a headache for you.
Right.
So whatever you do, the repair has to be robust.
So another flip side of these all inside is many times they fail to fire. So this sometimes occurs, and many a times we have to remove that with a punch forceps. And in the follow-up, yes, I agree with Dr. Maheshwari. Some of them do cause irritation, and we had to go in for scopy, and we found some these devices lying loose and removed, and even the meniscus has healed and they were still lying loose. So these things do happen. These are the flip side, but again, these are not very common.
Okay, I think Satpal, wonderful presentation, and we had a good discussion about this. Imran, are you ready with your presentation?
Yes. Yes.
I having one more case of PCL.
Okay, you want to present one more case? Okay, go ahead then.
This is on the PCL avulsion arthroscopic fixation. 22-year male fall from bike. Came to me with pain, swelling, unable to walk and stand without support. On examination, it's because of stress.
Screen is not moving, Satpal.
Yes, sir. Sir,
Satpal, we can't see your presentation. We can't see your presentation.
okay. Sorry.
Share your screen again.
Pardon. I can't hear you. Hello.
Where is your presentation? We can't see your presentation.
Satpal's
Okay, what you can
computer
do
is not.
is,
Satpal's computer is not behaving since this afternoon.
okay. So Imran, you can start with your presentation. Satpal can take up later. Imran, Satpal, you unshare your screen. Okay.
Okay.
Hi, it's
Okay.
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 Yes.
Now you can start. You can start, Satpal.
You can start. Dr. Satpal, you can
Okay.
start.
22-year male came with history of fall from bike. Is present with pain, swelling, unable to walk and stand without support. Due to fresh case, it's difficult to perform examination. There is a swelling, tenderness, and bruises over left knee. Posterior draw test was positive difficulty. This is a pre-op X-ray showing avulsion fracture fragment from posterior aspect of tibia. This is a pre-op MRI showing displaced PCL avulsion fracture. This is type 2 displaced fracture. Initially, I managed with for 1 week ice fomentation, posterior knee support splint, brace, dressing, and end infiltrate. After 1 week, I did arthroscopic PCL avulsion fracture fixation by using 2 suture disc and 1 fiber tape with single tunnel. This is a post-op X-ray with reduced fragment, and this is a per-op video, a small video clip. I had made 2 posterior portal, 1 posterior superior and posterior inferior. This is a fracture fragment. Fracture fragment reduced with PCL TBL jig, 2.4 mm 2.4 mm drill bit used to fix the fragment. It's over drill with 4 mm cannulated drill bit, and with suture relay technique, I pass suture disc loaded with fiber tape and reduce the fragment and fix entirely with on suture disc. This is a 3-month post-op result.
Okay, thank you.
Any comments?
Good fixation, and I think good result.
Satpal, so you
Yes.
did the surgery in 1 week post-op. So you would like to wait more because you do have a worry of compartment syndrome happening. So you do routinely after 1 week or wait some more time before you do this surgery? Any problem anticipating doing surgery in 1 week post-op PCL reconstruction? PCL repair, sorry.
Actually, there was not any huge swelling after 1 week. The knees look normal. Normally, I wait for 15 to 20 days in PCL avulsion, but in this case, I did after 1 week.
So does anybody do transseptal technique?
No, no, sir.
No, no.
Still not.
Mm-hmm.
Do you have any experience, Dr. Maheshwari?
Yeah, so no, Vikram does transseptal all the time. I never done it. I was little bit like this, but he started with transseptal right in the beginning, and I'm convinced that that's a better way of doing it, because the whole capsule lifts off and you can actually, it's a big room. In PCL particularly, everything you want to see. It takes a little while to get transseptal because you have to remove the septum, but visibility is fantastic. Everything is at the back of the knee. Your scope, your cannulas, you can make two medial, one lateral, everything is working so well. I was quite happy to actually see that transseptal look to me a better technique. Try maybe one of these days. And it's no difficult at all to do a transseptal, just remove the septum from behind. And it's not a difficult technique, but it opens up the capsule very nicely. The capsule under the pressure of the water lifts up very nice. It's like you remove fat pad from the front and everything becomes visible, something like that. So I'm convinced that transseptal gives a better visualization in that part of the knee.
So I think that a lot of people are young surgeons here. So would you give some advice regarding how to be careful about, everybody would have this question, how to be careful about neurovascular bundle? So what is your tips and tricks to be sure that neurovascular bundle is safe when you are attempting this difficult surgery?
So in the first few 100 cases, maybe, we were routinely doing the posteromedial safety incision as advised by Fanelli. And it was very, very, made the task very, very easy because you could feel your guide wires, you could feel your reamers, and the popliteal neurovascular bundle was at the back of it. So, but once the experience was gained after a few 100 cases, then we shifted to this all inside, and so we are not using basically the posteromedial safety incision. But yes, for the beginners, I strongly advocate that a posteromedial safety incision makes your job very, very easy while doing a PCL reconstruction.
Satpal, do you use a pump while doing PCL, and how do you make this pressure?
No.
Only gravity assisted. Okay.
Never. Only gravity assisted.
Okay.
I think the tip is you should be able to see it very well.
Yes.
If you're doing arthroscopic, spend some time, as we did in rotator cuff repair, you spend time in visualizing, removing everything. It is much happier. And from the days when we never used to use cautery or a RF device, I think in the knee, the use of RF device is very, very useful, particularly back of the knee. If you're not, don't use shaver, because shaver you're scared, they just pull something and cut something. But if you use nicely a RF device, it's very nice to elevate tissues here and there to improve your visualization as well as less bleeding. So use of RF device at the back of the knee is a very smart trick. I think that's what I would like to say.
Okay. So there are two.
Boss,
Yeah.
so Carlos,
Yeah.
what is the protocol of rehabilitation for this? How you rehabilitate the patient after?
For 4 weeks, non-weight bearing for 4 weeks with long knee brace, passive range of motion, and static versus exercise limited to 90 degrees for 4 weeks. And after 4 weeks, I start partial weight bearing. Full activity after 3 months. Sports after 9 months.
So only two comments. One is, if you are trying to use shaver blades while doing posterioscopy, use small mouth blades like cynovators or full radius blades, which come because their mouth opening is very small. So these blades are meant for working in those areas where you don't want too much tissue to suck into the shaver blade. 1, 2, you can have these spool cut devices, which a lot of companies now provide, and Arthrex usually provided it, because you can bend it. So if you bend it, you can have approachability all around. with the RF, you can't bend it. Sometimes approach becomes little difficult, though it is wonderful, as Maheshwari sir said. So cool cut, you can bend it with your arm and then you can use, it reaches everywhere. So you can have cool cut device when you are trying to do posterior scopy initially, because that is very handy sometimes.
Cool cut is from which
What
company?
Dr. Maheshwari was saying
Sir,
that
cool cut is from Arthrex, sir. Arthrex gives this cool cut. You can bend it little bit. So whichever way you want to bend it, you can bend it and do your job, and then again straighten it, again bend it. So that is that helps. It's very handy when you're doing scopy in regions where you want to be really very careful. Especially posterior scopy, I use this cool cut because Arthrex provides it.
And
for
also
this-
in case, as Dr. Pandey said, you find it difficult to reach. Sometimes the angle is not there, and you're
Correct.
using cannula. Just withdraw the cannula. Let the device be inside the device be inside the cannula, but withdraw the cannula. It'll give you more mobility to move take your instrument wherever you want. Exactly the way we sometimes do in bank card repair, because sometimes you cannot get the angle. You pull the cannula out. Don't take it away, but just pull it out so that it is out of the capsule, and then your mobility of the instrument becomes better. That will be another tip.
I think to clear the back of the tibia, if your scope is in the anterolateral portal, this posteromedial portal is very good. You can use your cautery RF devices through it, and you can use that even for retracting the capsule and everything to the back. So a posteromedial portal is earlier, as I said, we used to use that posteromedial safety incision, but this posteromedial portal and inserting an RF device, not only can we elevate the tissues from the back of the tibia, but it also acts as a retractor also.
Right.
Okay, so Satpal, you use this PCL zig for reducing the fragment as well. So you have to bring the fragment little down. So use that the PCL zig to bring the fragment down as well.
Yes.
Okay.
Occasionally, I use PCI elevator also to.
Did you get the CT scan before doing this surgery? Because sometimes these fragments are completely kind of, and when you're trying to drill these fragments and they are like shattering all around. So
Occasionally, but I prefer to do MRI instead of CT scan because.
Sir, what is your take on getting this CT versus MRI on trying to attempt repair of PCL?
If fragment looks comminuted or a small fragment, then I go for CT scan. Otherwise, if in X-ray and MRIs look big fragment, if fragment is more than 20 millimeter, I prefer to use this single technique. If fragment is comminuted or small, I prefer to use suture-based technique with two tunnels.
I think because MRI is a very standard investigation in these injuries, and I would think that there's no need to do another expense for CT scan. Rather, as an accomplished surgeon, you should be prepared for exigencies. For example, if the fragment is too small, you should be prepared to take suture bites from the base of the PCL and then pull it in. There will be always surprises where you should have a backup plan. So even doing an MRI may not help you because a good-looking chunky fragment may also decide to fragment when you are playing with it. So you should be having a backup plan. That is a better idea than spending money for just for seeing the size of the fragment. MRI shows it reasonable, though CT is a better one, but I don't think one would like to spend that kind of money just for that purpose.
Deepak sir, your indication of doing an open fixation of PCL avulsions. Did you ever try? It's all arthroscopy.
It's all has been arthroscopic. I don't have any experience of open.
Maheshwari sir, would you recommend certain spaces where we should perform, or it is only that if you can't do arthroscopy, do open? Otherwise, there is no scope of open PCL.
Well, even I would only say, and a lot of people are beginner, including me, in PCL repair. Let me very frankly admit, and I'm I always prepared to open it up if I'm struggling even 1%, because this is a very dangerous area. After some time, everything swells up, and you can create a disaster of damage to the neurovascular bundle. There is no fun. So unless things are going smooth, half an hour, 45 minutes, 1 hour, You are lucky, everything is falling in place, it's okay. Otherwise, after half an hour, 45 minutes, there is no shame in turning the patient upside down and opening up, particularly if you're not doing it, say, every week or every month. And most of us will do it maybe once in a month or 2 times in a month at the most. I will have no hesitation in opening up. It's a very dangerous area to play with if everything is not falling the way you like it. So there should be no hesitation. Even today, I will have no hesitation after about half an hour, 45 minutes. I find there is a mac around. I'm struggling with it. I have no harm and no shame in opening up and doing the job without putting the patient to extra risk.
Right.
Okay, I think we are running short of time. So, Imran, are you ready with the presentation?
Dr. Satpal, I have sent you email. You open my presentation on the mail. Open your Gmail. You share screen.
Actually, on my light up, I'm using laptop of a different of my friend.
Okay.
That's why I unable to open mail on this computer.
Okay.
By the time
I am sending email to you, Dr. Vinay Pandey. I am sending mail to you. Open your mail. Okay. It's on Google Sheets.
So by the time we are rectifying this, Amit can go ahead and okay.
Yes, sir.
Amit, you can go ahead and present your talk now.
My talk is on the meniscus to whether we can save it or sacrifice it.
Yeah, you start
but sir, I don't think that we are only 5 of us. So there is no point of presenting a lecture in this scenario. If you want, I will present. But it is, I think we ask some questions to the Deepak sir and Maheshwari sir. That is a better option rather than presenting a lecture on meniscus repair or sacrifice. What do you think, sir?
I think the people would be there on OrthoTV because this is being transmitted live on OrthoTV. So there will be some audience on OrthoTV.
Go ahead then.
Yes, then I will go ahead to share my screen. So this is visible?
Yes.
You can see. Yes. Go ahead.
Okay, sir. Save the meniscus when and why? Oh, I think there should be. My screen is not visible to me properly.
We can see you.
Okay.
Screen as well as you.
Thank you, sir. The big question is, does we save every meniscus? The answer is no. Appropriate and informed decision should be required. Only 20% of the meniscus are reparable. We can go on what is the function of meniscus. This is a transfer of load, shock absorption, stress reduction, stabilization, and lubrication of the joint. What is the biomechanics? In extension, the 50% of load is absorbed by meniscus. In 90-degree of flexion, the load sharing is 90%, and beyond 90-degree, the force is predominant through the posterior horn only. The biomechanics, the complete removal of meniscus result in 2 to 3 times increase in the contact stress. Removal of inner 1/3 leads to 10% reduction in contact area and 65% increase in the stress. Increased loss of meniscal tissue is equivalent to increase in the contact stress. Medial meniscus tear, root tear have pressure similar to the complete meniscectomy. This is the root tear. Imaging the plain X-ray to assess the bony injury or any changes in the joint of osteoarthritis. MRI is the gold standard to assess the tears. Meniscal excursion with the knee flexion is 11.22 mm excursion of the lateral meniscus and 5.1 mm excursion of the medial meniscus. Capsule, deep MCL, and the coronary ligaments. What is anatomy? The blood supply, the vascularized portion, the 30% of the medial meniscus is vascularized, 10 to 15% of the lateral meniscus is vascularized. Popliteal hiatus, posterior lateral meniscus have the worst supply. Commonly referred zones are the red zone, red-white zone, and the white zone. The red zone are the most talk about zone which we want to repair. These are the types of tear. I think everyone is knowing the types. What is the pathophysiology? Acute knee injuries with ACL intact, medial meniscal injuries 5 times more likely than the lateral. Acute knee injuries with ACL ruptured, lateral meniscus is more likely to be involved. ACL is previously disrupted. The lateral meniscus injury is more likely than the medial injury. A repetitive deep squatting result to the medial meniscus injuries, 20 times more than the lateral meniscus. So how to deal with them? One is the supervised neglect of the meniscus tear, and another, the commonly used procedure is meniscectomy, partial meniscectomy, and nowadays we are doing meniscus repair. Still elusive things are the meniscal transplant, meniscus scaffolds, or meniscal replacement. When to leave or neglect them alone? If the meniscal tear is undisplaced, stable medial meniscal or lateral meniscus tear. Short undisplaced, stable one, synovial abrasions. And short, stable one, trephination will help. Meniscal resection. The types of meniscal resection are the partial meniscectomy, subtotal, total meniscectomy. Resect as less as possible is the message, the conservative approach. This is some pictures of resection of the bucket handle tears. Now coming to the meniscal repair, why to do it? It helps to restore the function, maintain the load transmission, and minimize the contact stresses. It contributes to the stability, reduce the articular cartilage wear. What are the indications? The indications are reparability, if it is a reparable, healing potential, younger the patient, the biological manipulation, and more on the red zone area. Associated injuries, recovery time, consolidation, and patient referred. Relative contraindications are advanced osteoarthritis, complex tears, poor tissue quality, and ACL deficiency. Meniscal repair, when to do it? In acute tear, peripheral tears, red zone and red-white zone, unstable tears, tear length more than half of the meniscus, subluxation of the meniscal torn part in the condyles, young age less than 40 years, but Deepak sir had said he is doing up to 60 years, stable knee profile, avoid repairing of chronic complex tear, degenerative tears, unstable knee without reconstruction. And the rule of third, the ACL deficient knee 30%. If the ACL stable knee, 60%, and ACL reconstructed knee 80 to 90%. Associated grade 4 osteochondral defect and old age. The tear patterns, the horizontal tears are irreparable, longitudinal tears are reparable, radial and bucket handle tear are potentially reparable. Oblique or parrot beak tears and the complex degenerative tears are usually irreparable tears. Approach meniscal tear like fracture fixation. Preparation of the tear is a essential step. Consider the tear a non-union. Enhancement techniques, debride, abrade, trephinate, and clot. Reduce tear accurately and maintain the reduction throughout the fixator placement. Anchoring stitches, PDS or spinal needle aid in maintaining the reduction. Hybrid techniques are useful in deformed displaced bucket handle tears. Accessory portals to improve the access and fixation and configuration. Perpendicular placement of the implant every 5 mm. Grab circumferentially fiber bundles to ensure the optimal purchase strength. Ensure that implants are not proud, intra or extra articular. Avoid stuffing the meniscus with stress riser inducing implants. And the rehabilitation should be individualized. Protection of weight bearing when to start the motion and return to sports. Repair techniques we commonly use are outside in, inside out, and all inside. And the base techniques are suture based versus fixator techniques. Biomechanics of repair. Vertical sutures, resorbable anchors better to us. Vertical sutures, resorbable anchors, horizontal sutures, and mulberry knot. These are the pictures showing the techniques of repair: outside in, inside out, and all inside. Open repairs are rarely used. Inside out meniscus repair. Gold is standard for meniscus repair due to availability to place the vertical and horizontal suture on the femoral and tibial surfaces of the meniscus. Difficult to do in posterior third of the meniscus and required a dissection of the neurovascular structure. The technique, I think all of us are knowing the suture to how to do, and other is outside in meniscus repair. Suture passed through the meniscus from outside eliminates need for a larger incision, generally suited for anterior repair. Studies have shown similar or both results of both the technique. These are the pictures showing the outside in meniscus repair. The commonly used procedure is all inside repair. All inside repair device with developed to do the surgical time, prevent complication resulting from the external approaches, and allow access to tear the posterior horn. Fourth generation repair device allow placement of the suture in meniscus without the aid of an external incision or a suture fixator system. Self-adjusting with the anchor located behind the capsule with a sliding knot that can be tensioned appropriately by the surgeon. Mechanical studies show comparable strength to outside in sutures. These are the picture of the posterior horn repair by all inside technique. This is these are the ramp lesions. Tips for minimizing their adequate joint distension and visualization of the meniscus. Prepare the meniscus tear site properly. Choose the portal which allow the delivery needle to be inserted perpendicular to the tear. This is the technique. Outcome success rate of all techniques reported to be 70 to 95%. Second loop scope, however, lower success rate by 45 to 91%. Ligamentous laxity decreases the success rate to 30 to 70%. 90% success reported in conjunction with ACL repair. Transplantation, we are not using these techniques. The take-home message is not every meniscus tear needs repair. Plan for a repair surgically, judiciously. Use technique of repair in which surgeon is comfortable and convinced. Thank you.
Thank you, Amit. So we will shift to the last session of last presentation by Imran. Imran, should I say?
Yes, sir.
Amit,
Please.
stop sharing your screen.
Yes,
Amit, you stop sharing your
okay.
screen.
Yes.
Can you see the screen?
Yes, sir. We can see. Start slideshow, please. The first slide.
Just a second, I think. Okay, slideshow.
From the first slide.
Okay. So this is the case. Imran, you will speak. I will run over. As you say.
Yeah. Thank you.
Okay.
Yeah. Thank you, AAUP and Dr. Ashish Kumar and Dr. Vinay Pandey for taking initiative and giving this opportunity. And thanks Dr. J. Maheshwari sir and Dr. Deepak Chaudhary sir for as a panelist. This is a case of ACL tibial avulsion with tibial plateau fracture. Next slide, please. Next slide.
It's not breaking next slide. Okay. Should I go from there? Okay.
So this is a modified Mayers and McKeever classification. Next slide. Next slide. Type 1 is minimally or undisplaced. Type 2 is when the anterior beak is elevated. Type 3 is when the fragment is displaced and rotated. And type 4 is when the fragment is displaced and comminuted. Next slide. So these are options of fixation. This is staple fixation. Next slide. This is screw fixation. Next slide. This is
Next slide.
yeah, this is screw fixation options. And this is by fiber tape fixation or by suture bridge technique. So these slides are taken from Dr. Vinay Pandey sir's journal. And in this suture bridge technique, we clean the fragment, the margin of the fragment. Next slide. Then we burr the crater. Next slide. Then we temporarily fix this fragment with the help of 2 mm K wire. Next slide. Then we check the anteromedial and medial and anterolateral guide wires, the position of the guide wires. Next slide. Then we pass the fiber wire or fiber tape through the ligament. Next slide. Then we fix it with the help of either on the bridge, bony bridge, or a suture disc. Next slide. So this is a case of 36-year male who was riding a bike and hit on a cow, and there was severe pain, swelling, and this was injury 10 months back. Next slide. This was an X-ray. The X-ray shows there is the tibial spine avulsion, and also there is a tibial plateau fracture, and it was posterior medial compartment fracture. Next slide. Next slide, please. This is the MRI. The sagittal view shows the these are sagittal views. Yeah, this is coronal views, and
I think video will not be running. Request access. I don't know.
You click on it.
It's not running. No, I think it's not running.
Okay.
You should have a webinar on glitches in presentation online.
Correct.
Okay.
Somebody
Okay,
should.
then unshare. Okay, then
OrthoTV
unshare.
can maybe-
Okay, then please unshare. I am sharing with the help of my mobile. Please,
Okay.
please unshare screen.
Okay, should I? So this is, I think this is coming.
This is the post-op X-ray. Please unshare your screen.
Okay. So by the time Imran shares his screen, Satpal, what's your take on these? What is your indication of managing these fractures conservatively, ACL avulsions? When do you think of managing these conservatively, or it is always operative? Satpal, unmute yourself, unmute.
When
Yes,
ACL level
Prakash.
fragment is undisplaced, I go for conservative treatment for 6 weeks, non-weight bearing, walking, and start mobilization after 6 weeks.
Okay.
And if fragment is displaced, I always go for arthroscopic excision.
The key is it is very difficult to say whether it is displaced or not. That is the problem.
You say MRI.
For one surgeon it is displaced, for another one it is not displaced. How do you tackle
Yes,
that?
how to know? Because it can be minimally displaced for somebody. Somebody says it is displaced more than what is required. So how do you go about it?
And even on
Ashish sir,
MRI,
what is the protocol?
because even on MRI, because MRI shows so much edema, bone edema, it's very difficult to find out whether it is actually displaced enough to fix. The question is not displaced, question is displaced enough. So I have a practice, as you know, I'm mostly a referral practice. So if somebody advises surgery, they come to me. And let me tell you, this is one surgery where almost 50% of the times I would tell them you don't need surgery. Why you don't need surgery is this. If I passively extend the knee and the knee is almost comparable, sometimes they're 5, maybe 2-3 degrees short of the other side. But if the knee is not in flexion deformity and the fragment is not clearly avulsed, that means looking up into the notch, I treat them conservative. Because if the knee is fully extendable, this fragment will heal up there anyway. ACL is always attached on the posterior part of the fragment. So even if the anterior part lifts up, it is only a cosmetic thing. If it is not blocking the extension of the knee, fixing this fragment is only cosmetic surgery. You're going to make the X-ray look better. It will not be ACL deficient knee, it will not be causing block to extension. These are the only two things I'm worried about. And if on day one, I can get passive extension full, this is not indication for surgery.
Then how do you treat Dr. Maheshwari? What is your protocol?
I keep them in a brace in full extension or maximum extension, you can say. Sometimes even a plaster in full extension is in the cast for just 2 weeks full weight bearing. I don't think there's any concept of non-weight bearing here. If you keep the knee fully extended, there's no stress on ACL avulsion fragment, even after surgery. I don't think there's any concept of non-weight bearing as long as you keep the knee in full extension when the patient is walking. It's like a patellar fracture. When you're walking, the weight goes from femoral condyle to tibial condyle. There is no translation because the patient has a brace. So there is no, even after surgery or without surgery, in my books, there is no concept of non-weight bearing for and ACL fractures. PCL, I agree, but not in ACL.
So there are two situations here now. So once you say that you have to check for extension of the knee, so usually these cases have hemarthrosis. And this hemarthrosis in itself will cause block to extension. You will have a loss of extension because hemarthrosis is there. So would you recommend to drain the hemarthrosis before attempting to check for extension?
So let me tell you, they don't have significant hemarthrosis. Maybe by the time I see the hemarthrosis is gone. But you're right. If they're too painful, you cannot make that assessment. You can aspirate the hematoma. You can even examine under anesthesia. Give a short anesthesia, knee is fully extendable. Forget about fixation. So the question is, of course, because of pain, sometimes you may not be able to make that judgment. I accept that. That doesn't mean surgery. That means you take the pain away by whatever means and make sure that the knee is extending fully. If that is happening, I think surgery is unnecessary.
So now the second point is, if I am trying to aspirate a knee which has a hemarthrosis, sometimes this clot keeps coming in on top of my needle and the blood doesn't come out. Though you know it's a fluctuant swelling and you're not able to aspirate it.
Yeah.
So once in that you tell to aspirate, but it is not so easy. It is very disheartening to aspirate a knee which has hemarthrosis because blood doesn't come out. So what do you do then?
Oh, you want the trade secret? Okay. So whenever, and it is very embarrassing in front of the patient that you told him that I will aspirate the knee and it is swollen, but you can't aspirate. It's like, killing yourself. So I have this set of needles, which are from white needle, which is a available needle. Then I have a 2 millimeter, 3 millimeter, 4 millimeter, even up to 4 millimeter aspiration needles. With a trocar and cannula, you can give a stab, give under local, stab wound, and they go in. It's like arthroscope basically. You can put that under local in the suprapatellar pouch and suck it and the clot comes out. So always, and this happens with me, maybe 1 in 30 or 20 cases, that there 30 cases that there is a hematoma, I cannot aspirate. And that is a very embarrassing moment for a surgeon like you and me, that, doctor nikal hi nahi paye, blood to tha nikal nahi paye. क्यों नहीं निकाल पाए भाई? क्योंकि आपकी नीडल इतनी छोटी थी। अगर क्लॉट है तो बड़ी नीडल रखो, उसको स्टैब लगाओ. If you have decided to remove the blood has to be out, come what may. So I think if you start using, keep in your arthroscopy set aspiration needles 2 millimeter, 3 millimeter, 4 millimeter, and in such occasions under local anesthesia with a number 11 blade, just give a stab and take the blood out. It is easy.
So the take home is, I think one should attempt aspiration of these acute hematose knee, you keeping these cannulas or small bore needles
Yes.
with them, because they do get obstructed. So it has to
Yes.
be a full time putting a saline and pushing in the water, and then again aspirating and again pushing in the water. It's like that. It's more or less like irrigation.
Yeah, and if you
And
are,
just X-ray
let me go one step further. If you have you're an arthroscopic surgeon, you have a scope with you, you have a shaver with you, under local in the suprapatellar pouch, 2 stab wounds, like we used to do arthroscopy under local. You can put your scope inside, put the shaver from the other side, just shave out the. So point is, if you want to remove the hematoma, you want to remove the hematoma. How you do it is your business, without giving general anesthesia. Patient wants no anesthesia, no surgery, but the hematoma has to be out. So starting from taking out with a needle, having big bore needle, to finally even doing the arthroscopic removal under local anesthesia. That's not a big deal too, for somebody who's doing arthroscopy.
So what's your choice? Do you fix using these staples or screws, or it's like all arthroscopic fiber wire fixation or fiber tape fixation kind of? So Dr. Chaudhary sir, Dr.
Yes.
Deepak sir,
Yes.
what's your preferred method of fixing these fractures?
Of late, we have been using this mini tightrope with very good result. That gives a very strong fixation of the fragment. And mostly we have been
That comes with Arthrex, no? That comes with Arthrex.
Yes.
Okay, Imran. So we can
can
see
you
your
see?
video.
Okay, okay. Sorry for this
No,
glitch.
that's fine.
So this is ACL. This was fixed by fiber wire technique, suture bridge technique. This is the crater. This is the fragment, the avulse fragment. And this is the crater, which was shaved and cleaned. Then the fragment was reduced. Then this fragment was reduced and held with the ACL jig and with a guide wire. This is the guide wire and this is the ACL jig, with which the fragment was reduced and held. Then a lasso was put on the posterior fibers of the ligament. Posterior few fibers of the ligament. A bite was taken. Then suture was taken out. This proline suture was taken out, and over the proline, the fiber wire was tied. This proline was taken out, and fiber wire was passed through the back few fibers of the ligament. Then similarly, bite was taken anteriorly, and two suture disc wires were taken from the anterior fibers. These are the 4 fibers which are at the osteoligamentous junction, anterior and posterior. Then these fibers were after that tunnels are being made. This is the Intramedial Tunnel with the help of ACL jig. The Intramedial Tunnel was made just on the medial side of the crater. And I was making the jig as lateral as I could. because there was a fracture of the posterior medial tibial plateau. And this guider was taken out anteromedially. And then it was drilled with a 4 mm drill bit. And with the help of suture retrieval, these 4 strands were taken out through the 2 separate tunnels, anteromedial and anterolateral. Then after that, a trocar was inserted in the tunnels, and then plating was done. And these all the 4 strands were taken out through the tunnels, and it was tied over the suture bridge, suture disc. This shows the reduction. The ligament is fully tied, and with the help of probe, we will check the stability of the fixation. It was stable. Yeah, with the help of probe, you see that the fragment, the avulse part is totally fixed. So this was a post-op X-ray. Although the plate position was not the ideal one, and ignoring that, the ideal position of the plate, this suture disc was is shown in this post-op X-ray. But the avulse fragment, although it was looking reduced, but in the post-op X-ray laterally, you see that there is some anterior elevation of the avulsed ACL bone.
Imran, do you did both fracture fixation and ACL avulsion simultaneously, or
in the one go, in the one setting?
First you did ACL, then after plating, or
first I started with this 5-hour fixation of the ACL, but I did not completely fix that. I inserted 2 trocars in the anteromedial and anterolateral holes, and after that I did plating, and after completing plating, then I removed the trocar and take out the sutures, and then I tied the ACL, because I inserted trocar so that if any screw will strike the trocar, then it means that the tunnel is being breached. So first I started with suture passing through the ligaments, then plating, then final fixation to tightening of the over the suture disc.
You have changed the position of patient from lying. How do you fix this?
Yeah.
In prone position or supine position?
No, not supine. In the lateral position. Yeah. Right. Lateral position.
Okay.
In the lateral position, you had fixed it.
Yeah.
The plating was done in a lateral position.
No, in floppy lateral positions. Floppy lateral.
You make the patient prone for that.
No, it's not completely prone. Not completely prone.
And your incision is
in floppy lateral only. I sat on the keeping the patient on the floppy in the lateral position. I sat on the other side, and I elevated the gastrocnemius and I released the gastrocnemius, the medial head of the gastrocnemius, and I applied a plate on the posterior tibial.
You had applied the plate on the posterior medial side.
Yeah.
Not exactly the posterior, dead posterior, and the fracture fragment is posterior. The apex of the fracture fragment is
Yeah. The plating was done in a slight hurry, but that is not an ideal position of the plate. But overall, the plate held the fragment.
I think in this fracture you need 2 plates, the posterior plate and the posterior medial plate.
Yeah, you are right. Maybe
Imran.
Yeah, yes.
So we discussed something about your fixation of ACL avulsion. The position of suture disc would have been different, I think, if this fracture was not there. Correct?
Yeah. This is not the.
Because one of the principle of doing this suture bridge technique is that the pull of the fibers has to be in line with the ACL, to get an adequate compression all across the crater. So here the pool of the fiber wires are going to be eccentric on one side.
Yeah.
So I think this is because the plate is there. You would have made this sacrifice. And
Yeah. That is because I was scared of this tibial plateau fracture. So I kept myself as lateral as I could. And
How much time you take for this, both the procedures, and
Both
what
the
is the
procedure-
status of tourniquet? Do you release in between it?
yes, I did the ACL in the tourniquet. Then I released the tourniquet. Then I did plating, and
Again, you
yeah. Then again I elevated and did compression. I elevated the limb, and again yeah. So this was the 10-month post-op of the patient walking comfortably. This is flexion. This is squatting position, cross leg position. This is examination at 10 months.
webinar क्यों? बस 5
Deepak sir.
Yes.
So what's your cutoff for doing this repair with ACL avulsion versus doing a reconstruction? When do you start thinking, okay, now this is not going to go with the repair, I have to do a reconstruction in scenario of ACL avulsion? What's your cutoff?
No, the cutoff is like when we do arthroscopy, and if the fragment is very small or you cannot fix it, then I make the decision there only to reconstruct, because in my hand somehow reconstruction always works better unless I am able to achieve stable fixation of the fragment.
Okay, so you will prefer reconstruction over repair?
Unless if you don't achieve stable fixation, then the whole idea gets defeated. If you leave a lax ACL, then there is no idea. So we decide on the table, try to fix the fragment first, but if it is not, then proceed.
So if the reduction is not coming, suppose there's a fresh fracture and reduction is not coming, do you take off the intermeniscal ligament and then do a reduction, or you try to avoid it?
We try to avoid.
Taking off the intermeniscal ligament.
Yeah.
Okay.
So
Okay,
this was 10 months X-ray, and the fragment is almost completely united. The tibial plateau is also united. So the patient was started static quadriceps on day 1, range of motion exercises at 14 day. Range of motion at 14 day was only 30 degrees, and full range was achieved at 2 months. Partial weight bearing at 6 weeks and full weight bearing at 10 weeks. And still 10 months are over, then still patient has complaining of pain on prolonged walking, and there is some numbness over the shin region. So these are the 2 complaints of patient at 10 months in this case.
So Maheshwari sir, are you there?
Yeah.
So in a scenario of ACL avulsion, suppose it is an old ACL avulsion and you are going to take it off and do a reconstruction. Sometimes these ACL avulsions are flushed with anti-hun of lateral meniscus. So when we take this fragment off, the anterior root of lateral meniscus is hanging. There is no attachment left. So what do? You try to repair it, or you leave it there only?
Well, I'm very, first of all, I must compliment your team that I'm looking at the standard of care that you guys are doing, as well as presentation. You're doing all the recording, pro-op, pre-op, post-op, all that, and very, very impressed. Now, secondly, going back 20, 30 years or 20 years back, when all the shoulder surgery equipment was not available, it was really very, very taxing to do these surgeries in the beginning years. Like, we were one of the beginners. There was no suture passer, there were no tapes, nothing. So it was a lot of struggle, but I think it was a difficult surgery. It appears simple now in the hands of you guys when you do it. I still feel it is a difficult surgery. Now, coming to your point, old fractures, I must have removed the avulsed ACL fragment and not bothered about the ACL at all. at least in 20 cases till now in my career. And the reason for removal was they had a block to extension. They had no problem at all except block to extension. And I removed the fragment. I never tried to refix it. And let me tell you, not even one patient has come back with any problem. What I think is, what is happening is that a part of the ACL which is posteriorly has got fixed. And that is good enough to give stability to that person who is not a major sports person. So at least these 20 patients, no patient has come back to me. Yes, one of the reasons for block to extension is not only the fragment, but also with the fragment, the anterior horn of the lateral meniscus goes in and it becomes like a door stopper. And I have to cut that meniscus to get it out. I have never bothered to care about anterior horn of the lateral meniscus because I don't think it matters. It doesn't go anywhere. Peripherally, it is attached, and I don't think it causes any biomechanical or any problem about biomechanics of the knee. So my aim was just to get the flexion deformity out, for which I would remove the fragment, plus I would just cut off the anterior horn from the fragment so that it doesn't cause door stopper. Scientifically, yes, it doesn't look good. You should always fix them. You should also get the meniscus back. But very often I feel, you have to get into business. You have to get it right, get the things going. And if the patients have no problem, sometimes you learn from your past what you were doing and was it giving you results. If it was, I wouldn't bother to do too much just to satisfy my surgical skills. I hope that I have answered, or I have strayed away from your question.
No, you have answered. So you will leave that because root is like the silent epidemic and all those things are coming up.
No.
So a lot of time when we have to operate,
No.
is anterior root, correct.
Posterior root is a different game. Anteriorly, nothing happens.
Okay. So you will leave that anterior root, you cut that anterior root, and then you don't bother about it.
It will not be unstable because it's attached in the periphery anyway. And it doesn't come into biomechanics. When does the anterior meniscus come into biomechanics? In full extension. Okay, by the time,
correct.
Or maybe hyperextension, you can say. So that doesn't happen in normal walking. That kind of hyperextension is not common while weight bearing. In the weight bearing cycle, only in the first part you are hyperextending. That time there is no weight bearing. It is stance phase. So maybe I can try to explain that way, but I've had no problem, honestly speaking.
Okay. Satpal, any other question? Or Imran, you want to ask something?
Sir, when to remove the during the ACL avulsion fixation of the tibial avulsion, when to remove the intermeniscal ligament, transverse ligament, how to make the diagnosis and remove that to make the anterior beak of the ACL avulsed to press fit the anterior beak of the avulsed ACL, sir.
Yeah, I think you should remember, if you're not able to reduce the fragment and the fragment is good enough, very often intermeniscal ligament becomes a door stopper. So either you mobilize it and lift with some kind of a probe and put the fragment back, or you have to just even cut it to get a reduction properly. That spike remains in the air. If you're not careful about intermeniscal ligament, on the check X-ray, you'll find you can see the anterior beak already. So I think for reduction, sometime either pulling the intermeniscal ligament away or even cut it is required.
Sir, what I sometimes do is I downsize the fragment anteriorly, because anteriorly fragment is not holding the ACL. So
yes,
rather than compromising the intermeniscal ligament, I downsize the fragment anteriorly and then try to put it in the, maybe there is anterior depression which is evident then.
Yes,
but still it serves the purpose, because
I agree with you, but only question I want to ask you is, how do you downsize bone fragment arthroscopically?
No, I use a punch and just cut it. So
with punch you can't do it, you will spoil your punch. You need a very fine bone nibbler. I don't have that kind of a bone nibbler. I have thought about it, that somebody should devise an arthroscopic bone nibbler that you can punch downside it. Downsizing is no problem at all. You can leave that crater in the front, doesn't matter. But how do you do it is difficult. Punch is tricky because it will take the cartilage, it cannot take the bone. Or maybe you will spoil one of
So the
them.
video which Imran was referring to, in that whole video, you will see that I'm taking punch and little bit of downsizing anteriorly, because anteriorly usually it is a flake of bone. It's not
Maybe.
full-fledged bone. It's a flake
I
of
agree.
kind of cartilage, which is very thin kind of thing.
Yeah, maybe that much you can downside with a punch, I agree.
Okay.
But I'm
So
talking
I
about
think-
sometimes I've thought about fixing old ACL avulsions, and they become very huge over a period of time. Their downsizing is a headache. You cannot do it. You can use a bar, you can do whatever, you cannot downsize it. And those cases, sometimes I've felt that if there's an arthroscopic nibbler, a little more sturdy punch, you can actually nibble out tissues and then push the rest of it back. Just my thought, but obviously not common problem.
So it's always a pleasure listening to you, because I think of you as a living encyclopedia. So whenever I listen to you, I have so many things to learn from you that have been there for last so many years. And I think we are very blessed to have.
Sir, at times you can use the ronger, that spinal ronger. That can be tried.
Yes, that can be tried. But Vinay, you are saying in a very decent way that I'm an old man.
No.
We all remain students throughout our life.
I think we had the best teachers, because Deepak sir student you can find in any city of India, student from Safdarjung Institute working in any city, any all of our faculties who are sitting there must be having some friend of them would be working across like their city or maybe next to their city. And we all have read Dr. Maheshwari's book, so we are very fortunate to have you two on the panel, and we would be looking again to see you as on the panel again to make us learn something from you, great icons of Indian
Thank you, and I must say arthroscopy has gone a long way from where we started. I started, Deepak started, and it's so happy to see it being done so well in even smaller cities.
Yes,
very impressed.
Good work.
Thank you so much.
Thank you.
Thank you so much.
Thank you, everyone. Thank you.
Thank you, sir.
Thank you,
Deepak
sir.
sir.
Thank you very much.
Thank you.
Thank you, Vinay Pandey sir. Thank you, Ashish Kumar sir.
Thank you, everyone.
Okay. Bye.
Thank you, Deepak.
Bye. Bye.
और भी सिसोदिया,
जी
हाँ
बॉस।
बड़ी तारीफ हो गई आज तो, चौड़े हो गए। सही है
ठीक है, थैंक यू
चलो बढ़िया है।
थैंक यू।
मैं सुन रहा था पूरा।
आप कहाँ घूम रहे हैं?
अरे अब आए यार,
जगह मीटिंग में बहुत जगह आना जाना चलता है, सैटरडे को हर बार कुछ ना कुछ।
चलिए लखनऊ मिलते हैं, पार्टी बढ़िया रखिएगा।
हाँ नहीं सर, फर्स्ट क्लास है, बस सब देखो और जो लोगों को जमा कर सको जरा मेहनत करो उस पर थोड़ी सी।
जी सर, लेके आते हैं सब।
हाँ है ना, वो तो बता रहा है अमित मिश्रा की गोरखपुर में वो सब है, लेकिन फिर भी जो लोग
वो तो गोरखपुरियों के लिए है ना, जो गोरखपुर से बीआरडी से पढ़े हैं।
हाँ
वो तो सिर्फ
ठीक है,
जो बीआरडी से पढ़े उनके लिए, बीआरडी का सिर्फ अमित मिश्रा ही है और कोई नहीं है।
अच्छा,
उसको
जो है वो नहीं उसको उस दिन मत लाना, वो सेक्रेटरी है ऑर्गेनाइजिंग उसमें जो भी है। मैं ये कह रहा हूँ, दूसरी बात कह रहा हूँ कि इसी तरह से केस प्रेजेंटेशन होने हैं, तो जो केसेस है मैं जरा सा डालूंगा, तो एक आदमी जरा लोड उठाना और केसेस उठाने का।
जी बॉस जी,
है ना, जो प्रेजेंट करना पड़ेगा पैनल के पहले।
जी सर, जी
ठीक है ना, विनय से कंसल्ट करना, विनय को दूंगा वो सारे जो भी हमारे पास हैं, तो उसके हिसाब से कुछ प्रेजेंटेशन तैयार हो जाएंगे तो अच्छा रहेगा। ठीक है
जी बॉस, जी बॉस।
चलिए ओके भैया,
ठीक है सर, आप मुझे भी कुछ करिएगा, दीजिएगा।
चलो इमरान भाई, फोन पे बात करते हैं।
बाय।
अरे कैसे लीव करते हैं, लीव। चलो इमरान,
ओके बॉस,
चलो बाय बाय बाय।
बढ़िया रहा।
चलो हो गया सर।
हो गया,
चल बाय।
चलिए बढ़िया बॉस, बढ़िया रहा।
तो भी